Medical Tourism Corporation interview of Dr. Carlos Quesada, leading bariatric surgeon from Costa Rica.
My name is Carlos Quesada Ramirez. I am from San Jose, Costa Rica. I started medicine here, and then I started my residency in general surgery in 1992. It was for 4 years, and after this I got a scholarship from the Japanese government in order to receive training in the endoscopy field. So I received my training in the upper and lower endoscopy techniques, diagnostic and therapeutic. Then I came back to Costa Rica and started working with one of the biggest Class A hospitals of the social security system in our country, in San Jose. The name is Hospital San Juan de Dios, since 1999. And then I went to Mexico for 3 months in order to be trained in advanced laparoscopical approaches, like hiatal hernia repair. Then I started with bariatric surgery, especially in gastric banding, gastric sleeve. Then I went to Brazil and to receive training in gastric bypass surgery with Dr. Almino Cardoso. He's a very famous and very known doctor all over the world, making surgeries in India, United States, Costa Rica, Mexico, and everywhere. He's very famous. And I had received my training with him for 6 months. It was a very, very intense training, and I did with him at least 100 cases of gastric bypass Brooks and Y. Then I came back to Costa Rica, and since 2001 I started with bariatric surgery. That is my major in this moment. But of course we do, in my group, gallbladder removal, inguinal hernia repair, incisional hernia repair, hiatal hernia repair. So, but we are in this moment very focused in bariatric surgery. We do in bariatric field probably everything. We are making gastric banding, gastric sleeve, Brooks and Y gastric bypass, and MGBs, mini gastric bypass. We have to divide the bariatric patients in 2 big groups. Those people that are not sweet eaters, those people that doesn't like desserts, alcohol, drinks. So with this group, we can recommend the gastric banding or gastric sleeve. Of course, these surgeries are limited to just the amount of solids they can eat, but if those solids or liquids they eat are full of calories, the weight loss will not be so successful in long term. So we have to focus our attention in which patient will be good for gastric surgery and combining malabsorptive and restriction, and who or which patients are just for restrictive as restriction. Depends also what are the expectation of the people, of the patient in the weight loss and how many pounds, how many kilograms the patient is waiting to or expecting to lose, and how many months or years they want to lose that amount of overweight. So all those factors are important to consider which patients are for restriction, just restriction, or combined procedures. After 6 years and considering that we have almost 450 cases done up to date, we can see very good results with MGB, the mini gastric bypass. This is a very fast procedure. It's a procedure that takes 45 minutes or 1 hour and 15 minutes at the operating room. And the weight loss is very, very fast. And in long term, those patients, mostly of them, still have low weights after losing that overweight. So I think this is a very, very good procedure compared with the Roux-en-Y gastric bypass. Some doctors, and many doctors in the U.S. Consider that the MGB has one big problem. This is the alkaline reflux to this distal esophagus. I don't think this is very important because I can, after many years of doing this procedure and making endoscopical controls after surgery, up to date I have not seen just one patient with Barrett's esophagus. So I think considering this, I think this procedure is a very good procedure for anyone. We do not recommend revisions for everybody. Maybe we can discuss individually which cases can be performed, but we have to study very good the patient before doing the procedure. We have for metabolic surgery maybe 10 cases done. This is something new. Also, it reminds me that 2 years ago, I belong to the American Society of Bariatric and Metabolic Surgery, and they had changed the name of the society 2 years ago, adding metabolic surgery for those people with diabetes type 2, insulin dependent, and it's quite new, but we are starting with, and up to date we have done maybe 10 cases. We can do any of these procedures with people with body mass indexes less than 35 or 30 kilograms per square meter. I've been, for example, doing metabolic surgery in people with 20, 28, 29 kilograms per square meter, but insulin dependent, diabetes type 2. And the results after 1 month is incredible. They don't have to continue injecting the insulin. Then they just continue with something by oral treatment, and after 6 months, in 92% or 95% of the cases done, they don't have to take anything for diabetes. That's very, very good. First of all, we have to be sure that the patient is type 2 diabetic patient. This is the most important thing, that the patient is using insulin as treatment. They have to use insulin. So type 2 diabetic patients using insulin, dependent of it, they are really good patients for the treatment. Related with the weight, as I told you, we cannot consider this surgery. We don't have body mass index base for those people. So if I have a diabetic type 2 patient, insulin dependent, with a body mass index of over 20, 27, 28, probably I will recommend the surgery for those patients. Most of my patients done are from U.S., from Cayman Island, and Canada. Everybody, after receiving the treatment here, come back to their countries very happy and with a successful results in a very short term and long term.
Medical Tourism Corporation facilitates affordable medical and dental treatment at world-class international hospitals and clinics. Fill out the estimate request form on our site, medicaltourismco.com.